Welcome, everybody. Welcome to another episode of PEM Rules. I'm your host, Yaron Ivan, as usual, and today, another very important guest. As physicians or clinicians, especially in the field of emergency medicine or pediatric emergency medicine, we balance the very difficult balance of patient care while practicing protective medicine. We want to do what's best for our patients without putting ourselves at risk. Brady Pregerson is a medical legal expert who also is an emergency physician. He has done a lot of consulting in the medical legal field and reviewed many cases. He happens to be also an astute clinician. He contacted me a few weeks ago, and I thought it would be a great idea to have him on the show and talk about the medical legal medicine of pediatric emergency medicine. Brady also happens to have his own podcast in the field of emergency medicine, of course. And like me, he has written several articles to EP Monthly. You can check those out as well. So I thought it would be great to have him on the show. We actually have a lot in common. He likes good music too. And the field of medical legal medicine has always fascinated me. And I also must say, I know very little about it, so I thought it would be a great idea to have him on the show and learn from his experience and expertise. So, good morning, Brady. Thank you very, very much for coming on the show. I know you're a busy guy, and I appreciate your time. Let me just introduce you to the PEM Rules listeners. Brady is originally from Los Angeles. He went to undergrad and medical school at UC San Diego, completed his emergency medicine residency at LA County, USC in 2000. Since then, he's been practicing emergency medicine, lecturing, and writing about medical topics since 2004, including 3 peer-reviewed EM pocket references and 2 EM websites, which probably many of you know. One of them is emresource.org and em1minuteconsult.com. He also recently started his own podcast entitled EM Logic, which is produced by EM News. Currently, Brady works for 2 EM groups in northern San Diego. We have him here today as a guest on PEM Rules to ask him about rules and pearls directly related to his expert witnessed work, as he has reviewed more than 200 malpractice cases to date, with about 5 or 10% of them being pediatric cases. Is that right, Brady?
That is right. Yeah, that's right.
And I'm super flattered that Brady actually contacted me through the PEM Rules website because somehow he heard of me and actually quoted me in one of his lectures. Is that right?
Yeah, I use that all the time. It's not patients' job to prove that they're sick. It's our job to prove that they're not. And I think that's a great one. I mean, there's a lot of different ways of saying that, but I think if you approach emergency medicine that way, you're first of all going to have probably a better relationship with your patients because they don't feel like they're, having to, prove things. They don't feel that you're going to be dismissive of them, and you're not going to miss things as much. I think if you go in with that, another thing I just came up recently. I think as emergency physicians, we have to look for trouble. We go out looking for trouble.
I love that. That's very true. And again, I'm super excited that you heard of me and my website and my podcast, and you use rule number 1. It's rule number 1 for a reason. It's not the patient job to prove that they're sick. It's your job to prove that they're not. I tell that to the residents, the medical students, and now fellows all the time. So again, thank you, Brady, for coming on the show. And my first question to you, and if you listen to the show, you know what the first question is a question that I ask all my guests, and you are a very experienced provider. What do you think makes a good PEM or EM doctor in your case? What do you think is something that we as PEM physicians should do? What is your ideal PEM clinician?
Gotcha. Well, I think the first thing, we said, we sort of covered it, and there's a lot of versions of that. Think worst first, think worst case scenario, err on the side of patient safety. So you always have to keep that in mind. The problem is, obviously, we see a lot of patients who don't have serious illnesses. So you have to be looking for the needle in the haystack. And I think one of the first things is to approach our job not thinking, oh, here's another, I see people really do want to dismiss patients. And some of the complaints I get sometimes is, I'm dismissive, so I try not to be, but I think you have to think like a detective. There's something to solve. Look at the case as a challenge. And if at the end of it, you found nothing unusual, you've just found a cold, or you found anxiety causing chest pain or one of the, wastebasket diagnoses, fine. But don't start out with that assumption. Start out with the assumption that you're gonna be the hero. You're gonna, figure out this challenging case, even though most of them are boring. And I think that makes our job more fun too.
I agree.
So that would be one. So the second thing I already basically just said is, don't consider the most likely diagnosis until you've ruled out the more dangerous condition.
Okay.
So that's basically the same thing. And then another one I think is really important is really to be cognizant of false negative tests. And I think these are probably different in adults and kids. In adults, the best examples are, I think, a normal ECG early in acute coronary syndrome or MI, and same with normal troponin early on and in unstable angina. All the adult cases I review of missed acute coronary syndrome, they all had a normal first EKG and normal first troponin. Nobody, sorry, I shouldn't say normal, but they didn't have like obvious changes. So no one misses the abnormal test, but a lot of disease occurs with normal tests. And patients put a lot of weight in tests. They think they're perfect, but we shouldn't make that same mistake. And then the other one that I think is pretty common is, everyone knows this, is a normal head CT and stroke. I always tell my residents, a head CT rules out a bleed. It does not rule out a stroke, and it definitely doesn't rule out a TIA. So I think that's real important. And then in pediatrics, I think you're gonna. Well, I know I'm predicting your next question. Go ahead and ask your next question.
Well, those are really good points. So I guess what I hear you say is you need to think like a detective. A good ER doctor thinks like a detective. Ask the right question. I call it take a good history. Same thing. Don't seriously consider the most likely diagnosis, but you have to rule out the more serious, dangerous conditions. I tell that to the residents all the time. Don't get me a respiratory viral panel and diagnose the URI. Get me a chest x-ray and tell me the patient does not have pneumonia, for example. And yeah, what I hear you saying is be cognizant of false negative tests. Easier said than done, but I agree with all those points. My next question to you is, again, as a medical legal expert, the medical legal world of pediatric emergency medicine is a bit different from that of general emergency medicine for the obvious reasons. Different disease entities, different epidemiology. I would love to hear from you what advice you have for us PEM providers with regards to protecting ourselves while giving excellent care. I got to be honest with you, I'm not a big fan of practicing protective medicine. It's kind of something we all have to do. I always tell the residents, I want them to document protectively. I don't necessarily want them to practice protectively. So what advice would you have for us PEM providers?
Yeah, it's always a balance, I think, between, you can't test everyone for everything. So you have to, that's why where thinking like a detective, I think, comes in when something doesn't quite fit. Those are the cases that you pursue perhaps more testing. But, really your time in the worried well should be education. You spend your time on education, not testing.
I agree.
So in kids, I think, in addition to the stuff we discussed, I think vital signs are a challenge in kids because at every age, it's different. And I think every resource reference I've looked at, they have slightly different cutoffs for normal vital signs. And
Sure.
I think now with a lot of the EMRs, it's baked in. So that is quite helpful. But I still use my main rule of thumb is 165 minus 10 times the age is the upper limit of normal for a heart rate. So maybe my EMR doesn't work, or maybe it's not doing it. So if I have, say, a 4-year-old kid, I would take 165 minus 40, and that would give me 125. And that should be sort of my upper limit of normal heart rate. And of course, you have to take into consideration if the kid could be crying or the kid could be febrile. There's other things that could raise it. But
absolutely,
I don't want to send home a kid with unexplained tachycardia because just like in adults, that is a pretty good sized red flag. Now, if you have an explanation, I think it's less risky. It's just so much harder in kids because their vital signs vary a lot. And the other thing I think I see recurrently with kids when, cases that I've reviewed where something got missed is when a child has vomiting without diarrhea lots of those are, I mean, I tell probably every shift a parent, this is probably early gastroenteritis, but it could be all these other things. I think the risk is less than 1%. We're going to let you go home. You need to know these things reasons to come back. But when you're seeing a kid who has vomiting and doesn't have diarrhea, you have to start, thinking about other things. And some of those kids are going to need an extensive workup because they have something bad. A lot of them have early stomach bug, but some of them have something bad. And by diarrhea, I mean, they really have diarrhea, like watery diarrhea. So I probe if a parent or a patient tells me yes to diarrhea and they hesitate, they're like, do you have diarrhea? Yeah. Well, or even if they say yes, I'm going to ask, well, is it a lot of watery diarrhea or just a little? And I really want a lot of watery diarrhea or a lot of diarrhea for me to feel confident that to tip me towards gastroenteritis. If they have one loose stool, I don't count that as diarrhea. So I have seen that recurrently with missed appendicitis, meningitis, testicular torsion. I've seen a number of cases of that got missed, that ended up, in a medical legal case. And we want to prevent that. We want to not just document, we want to take the best care of the patient so they have a good outcome. So we're not a successful defendant. We want to be the hero.
Absolutely. Very good. So I guess what I hear you, and when we spoke for the first time, I guess you really have a lot of PEM rules similar to my rules. I guess you phrase them differently and maybe you use them differently. So now that I have you on the show and you actually have a lot of medical legal expertise being involved in those cases, why don't you tell us a little bit about your rules and how you use them?
Okay. So I think that vomiting rule that I mentioned, so I think you have a version of that as well.
Mm-hmm.
So the things that so my rule, I guess, would be vomiting without diarrhea is something bad until proven otherwise. So, with gastroenteritis early on, they might have pain, but they shouldn't really be tender. The pain should come and go. So you want to, palpate the abdomen well. I think that's pretty basic. If you don't have a good explanation, you want to check the testicles. You and I have talked before about a case where, most patients with torsion are going to complain of testicle pain, but some aren't. They're going to be embarrassed or they're going to have more referred pain. I haven't seen a case in a while of torsion, but I saw a case yesterday, I'm pretty sure had torsion, and he had testicle pain, but he also had left lower quadrant pain and left flank pain. And he was actually tender in all of those areas. So I don't know that every kid needs a GU exam and every kid needs a GU history, but if something doesn't fit, I'm saying, hey, sorry, we got to pull the pants down and I check.
Sure.
And vomiting, the kid yesterday didn't have vomit, but vomiting is a big red flag. Another thing when I lecture, I think a lot of people don't know about this. And I'll ask you, do you know about the JOLT sign or the JOLT accentuation sign or JOLT test?
So I got to be honest, I've never heard of it until I became an attending and worked with some residents. They taught me that.
So I did not learn this. Well, I'm glad some of your residents know. I find a lot of people don't know it. I did not learn it in medical school. I did not learn it in residency. I learned it afterwards. And I think it's very useful. I think it's highly sensitive for meningitis. It's the one exam feature I'm always going to do if meningitis enters my brain. And depending on the age of the patient, I might do it differently. So with a kid, I'll have them shake their head like a no really fast if they're old enough to follow. And if a kid's smiling when they do that, they're fine. With younger kids, I might grab their head and just give it a little shake and like make a game, like sort of growl or smile. And if the kid is smiling, the parents are wondering what I'm doing. I said, that's my check for meningitis. Your kid doesn't have meningitis. And if the kid's apprehensive, I might have the parents just bounce them on their knee, or if they're holding them on their shoulder, just sort of bounce them vigorously. And that is much more sensitive for meningitis than any of the things we learned in medical school. I mean, Koenigs and Brudzinskis are basically useless. Meningismus is probably 50-50. I think photophobia is pretty good, not as good, but that can be harder in kids, especially if they're preverbal. So really, this is a physical exam I want to do on any kid I think has any chance they could have meningitis.
Very good. Yeah, so definitely something for the listeners to check out, the Jolt sign. Again, I've never heard of it until I became an attending. And I've heard of it. I learned about it from some of my ED residents that do use it. So I'm glad you mentioned that. Any other rules, PEM rules that come to mind that you use, Brady?
Well, let's go to the testicle case. So I have a rule that any kid who's too young to drive is, in general, too young to have any kind of STD, epididymitis or chitis. So basically, testicle pain in those kids is torsion until proven otherwise.
Okay.
And I've reviewed I've had as many of those cases as any other pediatric cases of missed torsion, some with normal ultrasound. So the ultrasounds can be misleading. They can be normal in intermittent or partial torsion if it's only 180 degrees. They can have increased flow. It's called, I think, there's a term called luxury perfusion as well in brain injuries. But basically, if there's been a period of ischemia, I guess the body sometimes makes up for that and flow increases. So there can be increased flow in torsion detorsion. And what I've seen a lot and what I saw last night is, in this case, is there'll often be other findings that sound like it's a different diagnosis, but it's really related to the torsion. So a hydrocele can actually be caused by torsion, or what looks like epididymitis, it can actually be part of a torsion. So if you have intermittent torsion or partial or a 180-degree torsion, not only can you have a flow, so like a falsely normal test, you can actually have red herrings that aren't incidental findings. They're actually caused by the torsion. And so you need to really know that the ultrasound is going to be normal or even mislead you in probably 10 or 20% of cases.
Okay.
So what that means to me is if you have a kid in that age range where they really shouldn't be getting epididymitis or pain, or hydrocele shouldn't be painful, you need to not trust the test. There was a great case when I was maybe 10 years ago now. So it wasn't even a sign out. By the way, there's this 13-year-old. Oh yeah, he's going home. He's got epididymitis. I'm thinking, really? I talked to urology. Nothing to do on him. So before he left, he vomited, and the nurse, thank God, didn't just send him home. The nurse came to me and said, "Hey, can you check this kid out? He just vomited, and we're sending him home with epididymitis." I go into the room. I take a look at his testicles. He's got a horizontal lie and a high riding left testicle.
Wow.
I detorse it, and he says, "Can you show me how to do that?"
Wow.
The pain's gone, and when this comes back, so basically this kid had been having torsion detorsion and was being sent home with epididymitis. After discussion with the urologist, he had follow-up, and maybe he would have done fine. And of course, the urologists are going to say, "Well, why'd you detorse it? Now we don't know for sure." And I'm like, you don't need tests to always make the correct diagnosis,
I couldn't agree more.
So let's save some testicles.
I couldn't agree more. That's a great story. That's a great story. And I know, lastly, Brady, that you have some rule about vital signs. Can you tell us about that?
So I think, vital signs are vital. We say that in adult medicine. I'm sure you say it in pediatric emergency medicine. I think that you really want to scrutinize or decode the vital signs. I pay attention even to a temperature under 100.4. For me, that still bothers me. If it's over 98.6, I kind of, I'm not going to necessarily change my workup, but I'm going to notice it. If we don't really check blood pressure a lot in kids, but again, that heart rate thing we talked about earlier, have a formula in your head that you can do quickly so you can estimate it. Pay attention if your EMR flags vital signs. I ignore slightly elevated blood pressures all the time in my EMR. I think that's normal for the ER in an adult. But any tachycardia, and for an adult, I really use 90 as a cutoff. If I see someone with a heart rate in their 90s, a lot of people's normal heart rate is in their 50s. So 90 would be twice normal for some people. So I think paying close attention to vital signs and, repeating them, make sure they're not going in the wrong direction. I've had a number of cases where the last set of vital signs, not necessarily in kids, but some in kids, the last set of vital signs were worse, and then that sort of heralded a bad outcome. Okay. So yes, vital signs are vital. I think you have one of your rules is vital signs are vital as well. Am I correct?
So I have several rules that kind of go along the same things of what you said. PEM rule number 19, kids don't just vomit. Vomiting alone has a long differential. And sort of like along the same line, I'm always weary to call someone gastroenteritis when they are vomiting for 3 days with no diarrhea, no abdominal pain, no runny nose, cough, congestion, viral-like symptoms. If the kid just vomits, I certainly worry about CNS infections, which are the CNS tumors, which are the second or third most common tumors in kids after leukemia. And I certainly worry about DKA. I've seen that before as well. So the rule is kids don't just vomit. Vomiting alone has a long differential. And with regards to the vital sign, my rule is rule number 14, don't ignore unexplained tachycardia. So again, I'm always a little worried about a kid who's tachycardic without fever, tachycardic without screaming, crying, etc. To me, that's sepsis until proven otherwise or some other badness. Being a pediatric emergency medicine doctor, I see it all the time. Parents have a very low threshold to give Tylenol and Motrin because they think fever is the enemy. So a lot of kids come to my ER highly treated for fever, and when they're afebrile and still tachycardic, that makes me worried a little bit more. My anecdotal history with those cases is oftentimes, not always, but oftentimes I ended up finding appendicitis or some other serious diagnosis when I brought down the fever with some Tylenol and the kid is persistently tachycardic.
Yeah, I totally agree with adults as well. And then one other thing I wanted to say about fever, I think we're all taught in medical school, fever lasting more than 5 days, think Kawasaki disease, but Kawasaki disease is very rare in general. And one of the return precautions I give, you always talk about anticipatory guidance. The main return precautions I give with upper respiratory infections is if they're short of breath, if they have pain off midline or some unexplained pain. It would depend on the age. Everyone gets that pain from coughing right in the middle, but if you have pleuritic pain, and then the last one is fever for more than 5 days. So just like Kawasaki disease, fever for more than 5 days is a red flag, basically that it's not just a virus, because most viral infections, the fever doesn't last more than 5 days. It can. So I'll really tell patients, if it or parents, if the fever is not coming down in 4 to 5 days, they need to get rechecked. And that would be a kid I would typically, do an X-ray for to check for pneumonia. So that should be another rule of mine, I guess, is fever more than 5 days is something bad until proven otherwise.
Yeah, so that's also similar to one of my rules. The way I phrase it is work up the fever for over 5 days, or at least think about it. And again, along the same lines, for the most part, most URIs get resolved pretty quickly, especially in older kids, usually within 5 days. So after 5 days, I encourage the residents to think about Kawasaki. And that is something that is really, you can easily rule out for the most part by good history and physical exam, document no strawberry tongue, no mucous membrane changes, etc. And then you're all set there. But then again, if the kid is febrile for more than 5 days, I have seen cases of occult pneumonia, which my anecdotal experience shows that it has become more common. I'm not sure why, or certainly UTI or some other badness.
Completely agree.
Yeah, perfect. Brady, thank you so much for coming on the show. I think this was a very good session for the PEM Rules listeners to learn from. And I encourage you guys to check out Brady's podcast and his website. Brady, I understand you like Led Zeppelin and wanted to hear Led Zeppelin for the outro. Is that right?
That is true. I sent you a Led Zeppelin request for Over the Hills and Far Away.
Over the Hills and Far Away. I got to tell you, Led Zeppelin, amazing band. And I did do one outro for Led Zeppelin, one of my favorite songs by them, Kashmir, which was very challenging. I'm going to check out Over the Hills and Far Away and learn it, dedicate the outro, especially to you.
All right. Thanks. I remember when you did Kashmir.
Thank
All
you.
right.
Thank you very
Thanks so
much,
much,
Brady,
John.
for coming on the show. And I hope we can maybe do it again and learn from your wisdom.
All right. And I hope I really like your podcast, and hopefully some of your listeners will check out my podcast, which again is EM Logic.
Awesome. Thank you very, very much. Have a great day. And that is it for today, guys. Thank you very much for listening to PEM Rules. I hope you learned from Brady and his wisdom in an area that is certainly very important for all of us physicians, especially emergency medicine clinicians. This is Over the Hills and Far Away by Led Zeppelin. Obviously, I don't need to say, Jimmy Page and I are worlds apart. Hope you like it.